A 40-year-old female presented with fatigue, jaundice and pruritus for the last 2-3 months. There is no history of jaundice in the family, but she gives a history of pale stool. So identify. Pruritus word is given, pale stools is given. On examination, after what time MELD score is done? MELD score is done simultaneously. On examination, icterus is positive, so she is having jaundice, and this jaundice is obstructive jaundice, most likely from the clinical information of pruritus and pale stools. Now this patient has xanthelismas present. You can see here around the eyes, cholesterols are deposited. This is a case of xanthelismas. Per abdomen, there is no hepatosplenomegaly, no ascites. SGPT levels are normal. ALP levels are high. So ALP levels normal value of ALP. It is 50 to 150 international units per liter. It represent obstruction. It represent the obstruction. Okay, so I am getting the multiple answers. Some students are giving option A, some are giving option C. This is a case of, most likely a case of primary biliary cholangitis, but follow the protocol. Do not jump to the conclusion of AMA. So this is a case of, just a general case of obstructive jaundice. So when a patient comes to you with obstructive jaundice, why it is obstructive jaundice? Number one, features of pruritus, pale stools. Second, investigation, ALP is high. So whenever such patient comes to you, your next step is ultrasound for common bile duct. For common bile duct, do not skip this important test, important and simple test. So if the common bile duct is not dilated, or it is dilated, two things will be there, common bile duct. So if it is non-dilated, it means it is a case of intrahepatic obstruction. Dilated, extrahepatic obstruction. Extrahepatic are more serious. They can indicate a malignancy, pancreatic cancer they can indicate. So if it is a common bile duct dilated, then we can go for a MRCP, or we can go for a CT abdomen. These will be the tests which will be done to rule out the malignancy, While intrahepatic, there will be two important causes. One is primary biliary cholangitis and second is primary sclerosing cholangitis. So you go for a anti-mitochondrial antibody. If these antibodies are positive, so it will be more suggestive of, this is more suggestive of primary biliary cholangitis. While AMA negative, this is more suggestive of primary sclerosing cholangitis. So this is a formula. This is the formula. So in this, first we go for a ultrasound. If ultrasound is showing a non-dilated common bile duct, then we go for a AMA. Why these xanthelismas develop? Remember, xanthelismas can develop in any obstructive chronic obstructive disease, because of the decreased cholesterol excretion from bile duct. It leads to increased cholesterol in blood. because it is not able to excrete out. So any chronic cholestasis condition leads to a decreased cholesterol excretion and xanthelismas will be there. Xanthelismas will be there. Why non-dilated in intrahepatic obstruction? This is your anatomy. If there is a intrahepatic obstruction, the common bile duct is after the liver. It is after the liver common bile duct is formed. So the obstruction, if it is inside the liver, will not impact the common bile duct. It will not lead to common bile duct dilatation because it is inside the liver. Want the surgical jaundice patient present with a pain abdomen? Remember, pancreatic cancer, they are asymptomatic. Pain is in advanced stages. Pain is in advanced stages. So there might not be pain in such patients. Difference between obstructive jaundice and cholestasis. Cholestasis means bile duct obstruction, and if bile duct obstruction is causing the jaundice, icterus in the eyes, then it is known as obstructive jaundice. What is AMA? AMA is anti-mitochondrial antibody. Anti-mitochondrial antibody. Now coming to the next one. Okay, let's see. Same patient. This is we have already discussed in the previous clinical scenario. Patient underwent ultrasound. Patient underwent ultrasound, which shows no dilatation of the common bile duct. What will be the next investigation in identifying the etiology? So answer is anti-mitochondrial antibody. It is anti-mitochondrial antibody. Now, number 13. The same patient in continuation with the clinical vignettes has a positive anti-mitochondrial antibody. We did a liver biopsy which read as intrahepatic bile ductules, non-suppurative inflammation is present. So this is the most specific investigation for primary biliary cholangitis. Most specific. So which of the following treatment will benefit her? So the answer here will be ursodeoxycholic acid, the pharmacological aspects, integration with the basic subjects, allied subjects. Ursodeoxycholic acid, it solubilize the bile. It makes bile non-toxic. So bile is toxic to the liver. It makes it non-toxic, and very, very important, this agent is such an important agent that it stops the progression of primary biliary cholangitis. Stops the progression of primary biliary cholangitis. Steroid will be used for alcoholic hepatitis. Azathioprine will be used for autoimmune hepatitis. Now, come to the next one. So we move to the next set of clinical scenarios. So let me see who can give me the correct answer here. Question number 14. So question is a 60-year-old female. Now she present with skin tan. Skin tan is skin pigmentation. Shortness of breath. She has diabetes, joint pains. There is bronze skin pigmentation on the clinical examination. Icterus is noted. Yes, jaundice is there. Cardiovascular system. S3 is present. Lung crepitations are present. Arthropathy is there of the second and third metacarpopharyngeal joints. So what is this clinical case? So many multiple systems are affected here. So what are the clinical system affected here? Liver is affected here. There is a bronze skin. I will summarize the finding of this clinical vignette. Bronze skin is there. There is diabetes. There is arthritis. There is some sort of a cardiac disease with heart failure. Cardiac disease is there with heart failure. Lung crepitations are present. S3 is present. So all these combinations are the classical. All these combinations are the classical of primary hemochromatosis. Primary hemochromatosis. Yes, correct. So, what will be the next line investigation in this case? Hepatitis viral marker. So nothing suggestive of the hepatitis here, viral hepatitis. Serum ceruloplasmin is for Wilson disease. Nothing, no features of Wilson disease are there like KF ring, neuropsychiatric problems. It is not there. Transferrin saturation, yes, it will be elevated in cases of primary hemochromatosis. Anti-mitochondrial antibodies, they are present in primary biliary cholangitis. So 100% our answer is C. How can we differentiate a cholestatic pattern from the hepatocellular pattern of jaundice? Very, very simple. If SGPT, SGOT are high, it is hepatocellular. If obstructive jaundice is there, ALP, gamma GT will be high in that scenario. Also, in obstructive jaundice, bilirubin is not able to reach the intestine because bile duct is blocked. So, urine, urobilinogen will not be made because where is urobilinogen made? Urobilinogen is made when the bilirubin goes through the bile duct into the intestine. That bilirubin when goes into the intestine, it makes urobilinogen and normally it is excreted in urine. But if the bile duct is blocked, bilirubin will not excrete into the intestine, urobilinogen will not be made, it will be absent in the urine. So this is how we can differentiate obstructive jaundice. Since AMA is positive, it indicates autoimmune conditions, steroid should be given. No, steroid will not benefit in that scenario. Why CHF? CHF is there due to hemochromatosis causes dilated cardiomyopathy. Iron decreases the contraction of myocytes, so dilated cardiomyopathy will be there. Now, moving forward, the patient in the previous clinical vignette has elevated transferrin saturation, so the investigation that we thought we should do came out to be positive, and there was very high serum ferritin levels are there. Ultrasound abdomen, hepatitis B, no role of antivirals, that will be in chronic conditions. It will be chronic conditions. So ultrasound shows hepatomegaly without the evidence of cirrhosis. SGOT and SGPT levels were increased. Genetic studies were positive for HFE gene. HFE gene is the most common mutation in primary hemochromatosis. So, what will be your next step for the management? Next step in the management. So, the next step in the management will be treatment of choice. So, do liver biopsy for iron quantitation? No. This will be non-specific because other causes of high iron in liver can be there. So just proving that liver iron is high does not make it primary hemochromatosis. There can be other causes like secondary hemochromatosis. Like iron overload by repeated blood transfusions, repeated blood transfusions, or it can be alcoholic liver disease. Yes, alcohol, liver disease, ethanol effect is iron deposit in the liver. Same, NAFLD, non-alcoholic fatty liver disease can have high iron in the liver. So they are non-specific. Start the iron chelator agents. Iron chelating agents like desferoxamine is ineffective in primary hemochromatosis. Reason, because of due to very high iron overload. More than 20 gram iron overload is there in the body. Desferoxamine or any of the iron chelating agent will not be able to remove this iron. They will not be able to remove this iron. So only iron removed by phlebotomy. Phlebotomy means removal of the blood. One phlebotomy is equal to 500 ml blood is equal to 250 milligram iron. It is 250 milligram of the iron which is removed in one phlebotomy. One phlebotomy. So therefore, iron chelating agents not effective because of huge iron overload. Patient is having multiple organ dysfunctions like heart failure is there. No role of observation. Indeed, after the phlebotomy, patient heart failure will improve, cardiac condition will improve, cardiac condition will improve. If cirrhosis found in this patient, then we will go for transplant. Yes, we will go for the transplant if cirrhosis is there because of high risk of cancer in these patients. Now, moving on to the next one. Why don't we do biopsy? We may find other causes like genetic mutation has been done. Genetic mutation is confirmatory for a primary hemochromatosis. For a primary hemochromatosis, and there is no use of quantitation of the iron in the liver. So the option was quantitate the iron by liver biopsy. That is not appropriate management. All right. So now this patient of alcoholic liver cirrhosis presented with abdominal distension for the last 2 weeks. On examination, shifting dullness was present. How much ascites fluid will be present for a shifting dullness to be there? So the shifting dullness is कि when we percuss the central part of the abdomen, it will be tympanic because fluid gravitate to the flanks, and when we go towards the flank, dullness will be there because fluid is there. So central part of the abdomen tympanic, lateral part of the abdomen flanks will be dull. Now if you ask the patient to turn to one side, fluid will gravitate to the other side, and then you percuss once again, it will show tympanic. That is the meaning of shifting dullness, and the quantity of the fluid should be more than 500 ml. It should be more than 500 ml for this case. While the other sign, which is known as a puddle sign, but this puddle sign is now outdated sign. It is outdated sign. So outdated sign, maybe some examiner might ask you ki how much minimum fluid is needed. 120 ml of minimum fluid is needed. 120 ml is needed. While for fluid thrill approximate quantity needed is more than 1500 ml. It will be 1500 ml that will be needed. So you have done the clinical examination. So the clinical examination revealed that it is a case of ascites. Now the next question will be, if it is a case of ascites, do a ascitic tap. So how you should do a ascitic tap? So let's see this number 17 question. Ultrasound of the abdomen was done and ultrasound revealed that ascites was present. Now you are planning for the ascitic tap. So as a student or as a intern, what will be the best site for a diagnostic ascitic tap and needle size, and what should be the needle size? Most specific sign is puddle sign. No, it is not as such a most specific sign here. So we will go for a paracentesis. So where is the fluid best taken from? Best taken from. Suppose this is the abdomen. This is umbilicus. This is the abdomen. This is umbilicus. And this is right lower quadrant. This is left lower quadrant in the abdomen. Left lower quadrant. So where you should do the diagnostic tap. So the diagnostic tap best is done from LLQ. Reason, because it is, why it is best site? Reason is there are deep pockets of fluid. You will get a fluid easily. Deep pockets are there. And second, relatively less vascular site. Relatively less vascular site. Though you can do from the right lower quadrant, no problem in that. If it is a very tense ascites, huge ascites, you can take it. That is not contraindicated. But the question says which is the best site for a diagnostic tap. Diagnostic tap. So best site is deep pockets of the fluid you will get, as well as the relatively less vascular. But what is the needle size? So needle size for taking a diagnostic tap, answer is it will be 22G. So this is 22G. 20G is used for, this is a wide bore. This is a wide bore needle. So used for therapeutic tap. Okay, where is left lower quadrant? So the left lower quadrant is, this is umbilicus. So you draw a line from the umbilicus till anterior superior iliac spine. Anterior superior iliac spine. So draw a line and junction of 2/3, 1/3. 2/3 medial, 1/3 lateral. This junction is used for taking the ascites fluid. Ascites fluid. So this is umbilicus. I will label it. And this is anterior superior iliac spine. Draw a line. 2/3 junction of medial 2/3 and lateral 1/3. This is the site, best site to take the left lower quadrant. Now coming to the results, you did a sighted tap, so results are there in your hand. What is your diagnosis? Okay, for a therapeutic tap, same. For a therapeutic, it will be same. But though in therapeutic the ascites will be so tense that whichever side you can take, it will not make any huge difference practically. All right. Now the tests were done and they revealed that the serum albumin came out to be 3.5. Ascitic albumin is 2. Ascitic total protein is 2.2. Ascitic cells were lymphocyte predominance. What is the likely cause of this condition? So, is it a malignancy? Is it a spontaneous bacterial peritonitis? Or it is a cirrhosis induced uncomplicated ascites? Or tuberculosis has developed in our patient? So think broadly, all can be the causes in a patient of cirrhosis coming to you. So the first step is we will calculate SAAG. SAAG is serum ascites albumin gradient, serum albumin minus ascites albumin. We will calculate this. If more than 1.1, then do ascites proteins, total protein. If the total protein is less than 2.5, it is a case of cirrhosis induced. It can also be SBP, spontaneous bacterial peritonitis, while if it is more than 2.5, it is post-sinusoidal cause. Post-sinusoidal cause like CHF. While if it is less than 1.1, then it is due to tuberculosis, malignancies, nephrotic. So this is the most important flow chart for ascites analysis. Very simple flow chart, 2-3 steps only, but all the questions will be solved from this flow chart. So let's apply in our clinical case. This is the formula. Let's apply the formula in diagnosis. Serum albumin is 3.5, ascites albumin is 2. That means reference is 1.5. Our patient has a high gradient. Look at ascites total protein 2.2. Our patient either having a cirrhosis, uncomplicated ascites or spontaneous bacterial peritonitis. Ascites fluid are lymphocytes. For SBP, it should be neutrophils more than 250 per mm cube predominantly, then you go for SBP. Cirrhosis is lymphocytes only. So answer is cirrhosis. To rule out the malignancy from other causes. What is the concept of SAJ? SAJ concept is to rule out the cause of ascites due to portal hypertension or high sinusoidal pressure from other causes of ascites. Other causes of ascites. So TB malignancy will go in a gradient of less than 1.1. Now coming to the last patient coming to us in the emergency. So let's solve this case also. So a patient with non-alcoholic fatty liver disease induced cirrhosis present with altered sleep cycle and drowsiness. On examination, asterisks are present. He has an episode of melena 2 days back. Serum creatinine is normal. What is the likely complication of this patient? That is cirrhosis. That is cirrhosis. In SBP, SAJ will be less than 1.1 because of the inflammation. There is more ascites protein. No, the concept is Satya. The concept is SBP develop under the conditions of low proteins. Antibodies are protein. So if the proteins are low, local antibodies will be low, more chances of SBP, spontaneous bacterial peritonitis. So this is an important concept. SBP develop in a low protein state. It is a complication of cirrhosis. So Patient, what is our clinical diagnosis here? The clinical diagnosis here is patient has altered sleep cycle. The first symptom of hepatic encephalopathy. Hepatic encephalopathy. Asterixis, this we have discussed earlier also. So this is a case of asterixis. So serum creatinine is normal. What is the likely complication in this scenario? So the likely complication in this scenario will be, most likely complication, encephalopathy will be there. And what is the precipitating cause here? Precipitating cause of encephalopathy here is upper GI bleed, because melena history is given, upper GI bleed is there. So what upper GI bleed will lead to? Blood proteins, they will go to gut bacteria, and gut bacteria form ammonia. Gut bacteria will form the ammonia. So this is how the patient presented with the complication due to upper GI bleed, that is due to hematemesis leading to melena. Now my question is, in this condition, melena is there, what is the minimum upper GI bleed to cause melena? So melena is lower GI bleed? No, 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 no. It is not lower GI bleed. No. So melena is minimum blood needed to produce the melena. It is 60 ml. Yes, 60 ml is according to the Harrison. 60 ml is according to the Harrison. Yes, likely complication can be SBP, but in SBP, abdomen distension should be there. Ascites signs should be there. It can develop subsequently, but not presently. Not presently. SBP is spontaneous bacterial peritonitis. Now, coming to solving this clinical case, now your decision. Your decision as a physician sitting in the emergency, you assess the patient and the BP of the patient is 100 by 80, 100 by, 80 by 60. Blood pressure is 80 by 60. Icterus is present. No evidence of ascites. There is no evidence of ascites. What should be your immediate step in the management of this patient? So here the immediate step is written. So immediate step is patient is in shock. This is your immediate step. While IV octreotide will be drug of choice. While endoscopy, band ligation should be treatment of choice for ruptured esophageal varices. Yes, read the question very carefully. Ki what is being asked? What is being asked? So the immediate step will be IV fluids. Drug of choice will be IV octreotide, because it is a esophageal varices which must have ruptured in our patient, and endoscopy, band ligation is treatment of choice. Treatment of choice. So these were the few clinical vignettes related to the liver that we have discussed, and my advice is just go through this video once again so that you get a idea ki what is the meaning of a problem solving and analytical skills. How to develop the analytical skills? You will develop the analytical skills only with multiple revision and with such sort of sessions. So if there is any doubts related to this, you can put your doubts in the Telegram channel or in the Facebook DEMS Club, and all the very best for the whatever exam you are facing. And hopefully this session is useful for you, especially for a new pattern of exam, not only the new pattern of exam, but also to develop this clinical art of diagnosing and managing a disease. That is more important. That will be helpful for you throughout your career. So we will wind up this session, and once again, all the very best. Thank you, all of you.